said, my name is Dr. Laurence Gray, and actually I'm presenting this on behalf of a group of clinicians and pharmacists who worked to look at penicillin delabeling, and so a real multidisciplinary effort. As Kath said, I work as a consultant in acute medicine clinical pharmacology based here at Landock Hospital. So today we're going to talk about removing labels, which I think is something very important in medicine, and I think on a wider point of view is something actually really difficult to do. So once a diagnosis is made, it's very difficult to actually remove it. So what I'm going to touch briefly is a little bit of a kind of background kind of 101 ADRs, adverse drug reaction, a little bit about allergy. So that's going to be a very small part, but just to kind of set the scene as it were. And then I'm going to talk for the kind of second half or second 2/3 of the presentation about penicillin allergy. And of course, as Kath said, any questions that come to your mind throughout the presentation, just send them to Kath on the chat, and then she can interrogate me afterwards, and there will be plenty of time for discussion. It's important to say, I think, that our service, that when I'm working in the adverse drug reaction service, that not every drug reaction is not every drug reaction is an allergy. So that's the first thing to say. So our service is known as the adverse drug reaction service. And of course, there are multiple kind of effects that a medication can have on someone, but not all of those are allergic reactions. So one of the things to first decide is this form of adverse drug reaction or an allergy. And I've used this Aronson and Edwards' definition here. So a harmful or unpleasant reaction, intervention related to the use of a medicinal product. And of course, any harm or unpleasant reaction needs to be minimized. And also we need to look at investigation going forward to see if that medication is the cause of the reaction. And secondly, can it be used or an alternative treatment be used instead? So I've got this rather busy slide, which you'll all seen, I suppose, when you've gone through your studies, looking at the classification of adverse drug reactions. The most common, of course, are the type A reactions. So these would be sometimes you could see it as augmented. So it's an extension of the effects of the medication, such as postural hypertension, for example, with tamsulosin because of its alpha blocking activity. And then in B, we have this non-dose related, and these would really be your immunological reactions, your allergies, etc. And to remember that, I suppose you could classify these as bizarre. So these are the two most common, but this classification has been extended, as you can see below. So we are recording this talk, so feel free to have a look at greater detail at this slide if you wish. So just a little bit, and the thing that I suppose I want to put a bit of a message in here, I suppose, is about the key features. So one is the timing, because the timing will give you an idea about the type of if we're talking about allergy, the type of immune response involved, but also that patterns in terms of the allergic response will give you an idea, one potentially about the culprit medication as being which would be most likely. Just for your as a little bit of an aside, this pattern here is a Paisley pattern, which actually is from Paisley. And curiously, the Paisley pattern was actually developed in the 19th century, because patterns from India were very popular because and very fashionable. So actually, the Paisley pattern that has become very popular is a Scottish, I suppose, approximation of patterns from India. So a little bit about Paisley. I'm sure all of us, maybe some of us won't want to admit it, have an item with some Paisley shirts or ties in our wardrobes. So timing, so just important, I think, from all of us, whether we are working in secondary, primary care, whatever role we have, when we're thinking about allergy or adverse reactions to medications, it's the timing is really key, both in terms of the timing related to changes in dose, introduction, cessation of the medication. What about if there is an allergy? Has the patient had this medication before? I think it's very important just to remember that after the alleged allergic reaction, of course, you should really think about the immune system having changed from that time period. So the fact that the patient has tolerated a medication prior to the reaction, in some respects, does not mean a great deal in terms of future tolerability. So, for example, quite often we'll hear in the clinic, oh, I had previously taken X medication many times, and then, so it can't be this medication because I took this medication with another medication, so it must be the other medication because I had that medication before. However, actually, that's not the case. So once you've had the allergic reaction, it's only tolerance of that medication after the reaction that will suggest that you can tolerate that medication. We'll come on to that a little bit later. So the other thing to say is that in terms of kind of congenital disease and also in terms of carcinogenesis, also to look at that in terms of timing and how it fits with pattern exposure. So timing is really key in trying to delineate the mechanisms and potentially the culprit medications. I've just put this up. It's a really super busy slide, but it's just a few kind of side effects, immunological conditions that are associated with certain drugs. And I think for me, when I do these types of presentations, I always think this is quite a useful slide because it acts, many of you will be working in your clinical roles, and actually having this kind of information can be quite useful. So while not exactly relating to the penicillin labeling topic, I think this kind of summary slide is often quite interesting and useful. So moving on to drug allergy. So drug allergy refers to an immunological mediated reactions, and I think it's important to say that can be through multiple immune pathways. So typically in drug allergy, in terms of our investigation, we would talk about immediate or delayed hypersensitivity reactions. Now, many of you will be aware of the Gell&Coombs classification of drug allergy, which has been subsequently subdivided, but I think this acts as a good kind of foundation to act as a starting point to give a general overview. So the first point to mention is type 1, so IgE mediated, is generally an immediate reaction. We'll see that into minutes to hours to exposure to an allergens, and essentially it's the body sensitized with IgE on mast cells, and it causes inflammatory mediators and release of histamine. And this classic clinical manifestation of the urticaria, the hives, the wheals, the edema, and of course in severe systemic disease, anaphylaxis. Type 4 is the delay cell mediated, and we can see that in a kind of 24 to 72 hours sometimes. And that would be your generally skin reactions, but other systemic reactions such as dress, etc. So these are the two kind of most common reactions that we will look to test or classify in our drug allergy clinic. So just as a kind of aide-memoire, so we've got our IgE, which has been recognized an antigen, and as you can see here, it's on our mast cell. It binds the antigen, in this case we've said pollen, and you get degranulation of the mast cell with release of inflammatory mediators and histamine. Sometimes I think of the mast cell as like one of these balloons that you used to see, I'm showing my age here, and something like Cracker Jack filled with foam, and it pops and it just releases this large amount. these inflammatory cytokines and histamine, and it gives us the key features of this. So erythema, the redness, the urticaria, so that's the itch, the hives, bronchospasm, so you may see wheeze, the angioedema around the lips and maybe in the tongue and the throat, and of course the anaphylaxis, so that would be systemic features, so the profound hypotension and so on and so forth. So these are type 1 allergy reactions, and these are generally immediate, and I suppose to some extent are the best studied and the best recognized. Now, what I've got here is just a few, an assortment of various kind of guidelines regarding the evaluation of penicillin allergy. Most penicillin allergies that we will be referred tend to concentrate on type 1, but we will, of course, get people with more delayed reactions. So all these guidelines are really looking at a way to judge the likelihood of penicillin allergy, to risk stratify, and put in place a standardized process to evaluate the patient with a presumed allergy to penicillins or other beta-lactams such as cephalosporins. So when we look at these pathways, they all have a degree of consistency. So the clinical history taking, the time of onset, so all these factors I talked about that you need to elicit from the patient. But also we need to think about our investigations, our tests that we're going to do. And generally the standard format of performing or investigating penicillin allergy may involve specific IgE. So we can have specific tests to see if there are immunoglobulins against penicillin and penicillin components, skin prick testing, intradermal testing, and drug provocation testing. So this would be your standardized penicillin allergy investigation. So if I were to receive a referral in the adverse drug reaction clinic, depending on patient consent and likelihood of it being an allergic reaction, this would be the standard process that we go down. So a little bit about what skin prick testing is. So it's an outpatient, something that we do in the outpatient department. We have to consent for severe reactions. So with skin prick testing, which I'll just describe the process, is very, very rare, and there's never been a death from skin prick testing recorded. And we would tend to test with the index compound. So if the person had reported an allergy to amoxicillin, then we would skin prick test with that and also our kind of penicillin components. And that would be read after 20 to 30 minutes. And a positive result just shows an increase in the size of the wheal 3 millimeters greater. So that would be the positive results to suggest there is a potential allergy. The next step is intradermal testing, and forgive me, the photos may be a little bit on the grainy side, but what you can see is that we've got a syringe here into the forearm, and with a small needle, a tiny amount of fluid, 0.2 mils to 0.03 mils, I should say, of the allergen is then injected under the skin to make this little round bleb. And the advantage of this process is that it is much more sensitive than skin prick, but there is a greater potential for it to potentially cause an allergic reaction because it's a little bit more invasive than the skin prick, where you're just putting a tiny little amount of the medication onto the skin and pressing it through. Whereas in this way, you actually are introducing, albeit a very small amount of the substance underneath the skin. So it can be a little bit more difficult to read because you're causing a little bit maybe more agitation at the injection site. Furthermore, though, the utility of this really is, as I mentioned before, we tend to think about these reactions in terms of type 1, our immediate reaction. Skin prick testing is really great for looking at that, and is pretty sensitive. Intradermal testing has the advantage that it will allow you to look for a type 1 immediate hypersensitivity reactions, but it will also pick up delayed reactions, so type 4 type reactions as well, which skin prick testing generally won't, or is not validated in doing so. So even though it's a bit more work to do, it's slightly more invasive, it does have utility in the diagnosis of drug allergy. But because it's a little bit more complicated, it tends to only be done in specialist centres such as allergy, general allergy services and drug allergy services. So what I've got here is actually just someone's arm who's gone through some penicillin testing. So what we've got here is the PPL, so as part of the penicillin, and then we've got the minor determinant here for penicillin, and you can see above here we've got the control. So on the top right hand of your screen, you'll see that there's a positive control. So sorry, it's maybe a little bit faint, but you can see there's this lovely red response. So generally, we will use as our control as histamine. And here we've got a negative control, so no response. So that's exactly what you want to see, because if someone starts responding to a negative control, then they're not going to respond to the substances you're testing. And we can see if we go down here, that in the penicillin 1 to 10 intradermal, we have a nice reaction. 1 to 1, once again, another nice reaction, and intradermal ID down here, a nice reaction. There's probably a positive reaction there at the 1 to 10 as well. But just to say, there doesn't seem to be much happening with the prick tests. So this is just to illustrate that intradermal testing can add a diagnostic benefit to the testing and evaluation. After doing so, we then move on to drug provocation testing, which is the administration of the likely culprit drug in a controlled environment. And we would perform this if the skin prick testing and intradermal testing is negative. And that is the nearest we can get to really demonstrating a drug may be safe to use. And it can also, of course, be beneficial to the patient in that it gives them the confidence after having taken the medication themselves to take further courses, which of course is the name of the game. So as you can see from this process, and what I wanted to go through and explain it, is not only for you in terms of your general knowledge about what I get up to in the drug allergy clinic, but you can see it's a relatively intense process. We're going to have an initial clinical consultation, at which point I may or prior have ordered some blood tests to check to see if there was any kind of evidence of allergy. And then if we think it's worth investigating, we're then going to have a further appointment where we're going to go through the skin prick testing and then go for intradermal testing, and at some point also organize drug provocation testing. So is there another way that we can do things? Is there a way that we can look at penicillin? And I suppose the other question is, why penicillin? So just to get a little bit negative, is if we haven't had enough negative information for the last year or so hopefully things are on the move. In 2050, it is thought that 10 million deaths will be attributable annually to antimicrobial resistant organisms. So we now have a very real issue with how we're going to tackle this situation. And through that is going to be really the cornerstone is going to be antimicrobial stewardship and using the correct and appropriate antibiotics for treatment of these infections. And what we want to do is at all possible cases use these things such as as penicillins were clinically indicated. And if that allows us to save and utilize other antibiotics appropriately, then that will have a significant impact on our antimicrobial management going forward. So we have, this is, I guess we've gone through a tough time, as I said, but so this is something that is current and we need to be, certainly need to be aware of. It's also important to say that penicillins, though penicillin allergy is relatively common, we've had a huge amount of people exposed to penicillins. One paper has suggested over 100 million people have been exposed. Of course, that's through many generations. And there's only really been one death attributed to oral amoxicillin. So this is still, even though we spend a lot of time talking about the dangers of penicillin allergy, which from a medicine safety point of view, of course, is absolutely important in the correct documentation of allergy. Just to say, though, that in terms of oral amoxicillin, only one death has been recorded at time of writing. So, but what about the documentation of allergies? So as I touched on at the start of this talk, we need as much information as possible to be able to evaluate the nature of an allergy, the timing, the symptoms, and I suppose the pattern of what exactly happened. And in this study, or review, I suppose, which is well worth reading from Shenoy, it was in JAMA in 2019, they've, quote, 10 to 15% of inpatients have a stated penicillin allergy. And about 90% of these are unsubstantiated, i.e. that when testing was performed on these patients, and now whether you can extrapolate this to wider, it's always going to be difficult to say, but 90% are actually unsubstantiated. So only of this group of patients, only 10% have a true allergy, and the other 90% have something else. Now, it may be a significant adverse reaction, which would preclude them from having the medications anyway, but it may not be anything at all. And therefore, potentially, 90% of this group are being denied a treatment that could be beneficial for them going forward, and also beneficial for the population as a whole in looking at the ways that we use and utilize antimicrobials. It's important to say that penicillin allergy is not a benign diagnosis. So when someone has that, they will be generally, we will see that they will not receive potentially the first-line antibiotics prior to surgical procedures for any common infections, particularly where penicillin-based medications are kind of fundamental. A recent example, I've been involved in a couple of examples with patients with syphilis recently who have penicillin allergies, and it becomes very complicated, and the history of the allergy is really key in deciding how best to manage it. So what we can see with penicillin allergy when people have looked through the studies and the review of the effect that's had on patients is that generally they have taken longer to potentially recover from their infections. They've got an increased likelihood of actually being readmitted to hospital. MRSA is more prevalent in this group, and also those healthcare costs due to length of stay, etc., is also increased. So there's a real need to make sure we kind of address this at source. So I've done this little graph here, and being from Scotland, I've singled Scotland out, but it's also quite handy in terms of population. So if we think that 10% of the UK population, based on roughly extrapolating the Shenoy figures, and we're seeing only 10% of those have a true allergy, so that's 1% of the UK population, then we've got 9% of the UK population have an unsubstantiated allergy. 9%, now, as I said to you, some of these may be adverse reactions that will preclude use of the medication anyway, but the point being, this is a large group of people who are potentially being restricted from a medication that may be helpful for them going forward. And I suppose what I'm trying to say is we need to think how we can do something about that. But the sad fact of the matter is that most patients will never undergo an evaluation of their allergy, and it will just sit there on their clinical record, largely unchallenged. And I think it's important to say that that is understandable. If you are treating a patient and there's no blame, I suppose, that when a patient has a penicillin allergy stated in the record, that you are going to use another medication, particularly if the history is maybe unclear. But we should be thinking about how we can delabel, get rid of these penicillin allergies. And why is it not happening? Well, as you can see, the whole procedure is quite time consuming. If we take this large population of people with unsubstantiated allergy, or all this large population with stated allergy, there is no way that allergy services, not just drug allergy services, but allergy services would be able to process all those patients. Also, allergists, immunologists tend to live, work in tertiary areas. So there's also an issue about access to these services. And as you can see, the procedure of working through this is also quite time consuming, with a kind of evaluation appointment. So even if you were to bundle it up in all one thing, you've still got a lot of time and resource spent on removing these allergies with the traditional pathways as highlighted before. So my next question, is there a better way? Well, I guess if I ask that, then I guess there's going to be. So we're going to talk a little bit about penicillin allergy delabeling and taking it forward. So I think the first thing that's really important to say is that studies have shown that you have low risks and high risk. And if you actually look at all the guidance, even guidance that's not necessarily talking about direct delabeling of penicillin allergy, risk stratification is important. So getting the story will give you an idea about what you are happy to maybe treat or test with a penicillin, and this other group that you maybe have to be a bit more careful with and would need the more traditional type of pathway. So things such as that the reaction didn't require admission to hospital, the symptoms themselves aren't allergic, there was a rash but there was no evidence of urticaria or hives, and then in the high risk, things systemically unwell, wheeze, dyspnea, or any type of angioedema, an anaphylaxis, treatment required in hospital will be high risk features where you're more likely to go around a more conservative, cautious approach in terms of the evaluation of the stated penicillin allergy. So I think this is a really nice study from Dr. Louise Savage, who's actually an anaesthetist, and her husband Sunisa Savage, I think, who was an immunologist up in Leeds. And what they decided to do was look at could they delabel penicillin allergies ahead of elective surgery. So where penicillin was required, and people were noted to have penicillin allergy, they would then take them to a special clinic where they would then delabel them with penicillin. And they used the following features. So the low risk symptoms, as I said, they initially said the reaction occurred greater than 15 years ago. There's some suggestion, or it's known that skin prick testing and those modalities actually with time, they can lose their sensitivity. So once you get 10 to 15 years out, going through the skin prick and intradermal testing procedure, as I outlined before, becomes less sensitive. So on an ethical level, there's no point in doing a skin prick intradermal testing if it's not really going to give you the sensitivity that you want. There was sufficient time for testing before the operation. The patient was happy to have it. And they also put that it requires penicillin for surgery. So the two they altered there were that there were a few patients where they felt who had reactions less than 15 years previously who were happy to have, and they were met all other low risk criteria. And there were some patients who attended, even though they weren't going to have penicillin prophylaxis, were very keen to be delabeled from their penicillins. And as we can see, unstable asthma, high risk symptoms, as we talked before, anaphylaxis, angioedema. The patient didn't want to have it. And as I said, that eligibility criteria on penicillin for surgery was changed as well. So essentially, they managed to take 56 patients in this group and went through a 3-stage drug provocation test without any skin prick testing or intradermal testing. And they had 55 of 56 patients were delabeled with penicillin allergy. Now, of those, that one positive patient was very keen to be delabeled and minimized the symptoms, even though they knew the symptoms, they minimized the symptoms they had with their penicillin reaction because they wanted to be eligible for the delabeling process. So in retrospective review, when they got the history from the patient, they had the reaction, but it wasn't an anaphylactic reaction. The patient came out in urticaria. And interestingly, even though the follow-up numbers were small, of 19 patients who were followed up through to their surgery, 17 of those 19 received penicillin rather than the second-line agent, which is teicoplanin, which, just as a matter of point, can also cause type 1 immediate hypersensitivity as well, which is well recognized. And patients generally were very satisfied that they'd managed to remove this label from them, because many patients were quite frustrated when they received medical care that they weren't able to receive the full choice of antibiotics that others were. So in Blumenthal, a similar time period was looking in America, once again with Shenoy and Wickner, looking at a multi-hospital implementation of this through a micro guide type protocol. And this was, the idea was, initially it was on paper, to look at risk and then treatment. And they were able, through the healthcare model in the US, to look at how, if this was scalable throughout the organization, what kind of savings, and those savings were in the millions of pounds, because, as I said, penicillin allergy is both costly to the patient and to the organization. I've just put up their protocol, where if you look to the right, which I've highlighted in the box, you've got these mild reactions. So these would be equivalent to the low risk. And if you look down, what they're saying you should be doing is that you could go straight to a 3rd, 4th, 5th generation cephalosporin. So some of you may be aware that in these mild penicillin reactions, where people are needing intravenous treatment, for example, ceftriaxone has a very low level of cross-reactivity. Or the test dose procedure. So once again, there's no mention of skin prick testing in this group of people with mild reactions, and moving on to just a test dose procedure, usually with amoxicillin. I talked a bit about, this is from the Shenoy paper, as I said, and this is kind of the document that they produced for it. So you've got these intolerance histories, which would be seen as non-allergic, and then these low risk histories, and then they classified it further into moderate and high risk. So you can see that, as I said, there's this theme coming out, this idea of the risk stratification of penicillin allergy is absolutely key in shaping your evaluation, investigative strategies, and also in terms of, in the here and now, in terms of treatment, because potentially your history may allow the patient to access a larger group of medications, particularly within a low risk allergy history. Just to say that they had the direct procedure for low risk patients, so it tend to be a 1-dose test. And for those moderate risk patients, they did a 2-step challenge. So giving a 10% dose and then a 100% dose. So they, in terms of their stratification, they looked at this moderate risk, so slightly higher risk patients. They had a slightly more cautious provocation test. But it's important to say, so a lot of this work has concentrated largely on doctors, and I just wanted to spend a little bit of time just highlighting that this is a multidisciplinary approach, and that's reflected within our penicillin allergy delabeling group. And as you can see from this was a pharmacist-led penicillin allergy delabeling service in the journal, this happened in New Zealand, and reported in the Journal of Antimicrobial Chemotherapy. There's a horrendously busy slide, so forgive me for that. Maybe something if you want to look in great detail, you can look after the talk. But I think the key thing is if you follow right down the middle, and essentially you get to the point, was the allergic reaction more than 5 years ago? You answer yes. Were systemic symptoms present, fever, angioedema, or severe cutaneous reactions, so blistering, rash, mucosal involvement, something suggestive of TENS or SGS? If its answer is no, then once again, direct oral challenge, no need for skin prick, intradermal testing, etc. So, and this was led by a pharmacist-led intervention. So it's important to say that at the moment, if you think about it, we've got a situation where these evaluations of allergy are happening on a sporadic basis, and the more in-depth evaluations are happening by specialists. But actually what we're now seeing is that if you use validated criteria in terms of risk assessment, then you can actually allow this to be kind of democratized, I suppose, and many different specialties and many different clinicians to get involved. I like this study. This is from the United States Marine Corps, and they took a very practical point of view. So essentially, prior to joining up with the Marine Corps, because of the risks of diseases being shared among the Marines, they were all given penicillins, but of course some of those recruits had penicillin allergy. And what used to happen was that there would be a kind of allergist present, and they would take a history and then maybe skin prick testing, and they'd work through it in a kind of, I suppose, the old-fashioned way. But the problem was that the resource in terms of clinician access, the number of patients was very difficult to manage. So in a very practical way, this group in the United States Marine Corps basically used these low-risk criteria and just gave a test dose of penicillin to over 328 recruits. And only 5 had a reaction, and none of them had a significant reaction. So it was just a skin reaction. So no severe reactions. So a very proactive approach from our kind of military colleagues here, but demonstrated quite nicely that in this group, and I suppose outside of a kind of hospital setting per se, that this is a procedure that could be performed. Furthermore, in other patient groups, so not only in the kind of inpatient admissions, which is kind of where we are, cancer patients, for example, Trubiano did this nice study, and basically they managed to not only delabel 46 patients with oral challenge, they also managed to demonstrate that within 90 days, those patients who received penicillins, of which there were 26, 22 were given a penicillin. So not 100%, but certainly for those 22 patients, they're on, I suppose, have been effectively delabeled, because they're not only have they had their label removed, but they're now actually receiving the penicillins and things that they need. So a little bit now about our local protocol. So this is as I said, I think I should emphasize, this is a real group effort and across specialties and disciplines. So we've had help from Dr. Richard Cousins, who's a consultant immunologist, Ruth McAleer, who is our lead antimicrobial pharmacist at Cardiff Vale University Health Board, Dr. Owen Seddon, consultant infectious diseases, and Dr. Nico Sweetenham, who's a registrar in infectious diseases. And it's taken a long time. COVID kind of got away in the way a little bit with the development, but it's really through the sharing and the working together with this group that's allowed this this to move forward. And so all this work that you're about to see is certainly not my my sole work. It's the work of this group, and I think I just want to make that entirely clear. So what did we produce? Well, we wanted, so the PADL, so Penicillin Allergy Delabeling Toolkit, so the Cardiff Vale University Health Board. So we needed to develop a protocol for the process, a risk algorithm to identify suitable patients, who we were going to include, and how are we going to challenge them? As I mentioned before, some patients had a direct challenge, one step, full dose. Some protocols had a two-step challenge. Patient information leaflets. So there's pre-test information which needs to be made, including a consent form and information for after the test. The patient needs to know what happened to them. The clinicians who will be looking after them, such as the primary care conditions and also any other secondary care doctors, need to know that this test has happened for it to have its full utility. How, if we're going to roll this out to wider, how would you manage an allergic reaction? And also some information for the clinicians as this moves wider, how they will interpret the test. And we also produced a set of standard letters for the patient's GP so that negative, positive, or equivocal test results and the actions required could be communicated. Much of this was based on the great work done by the Scottish Antimicrobial Prescribing Group, who, if you go into their website, have a wonderful toolkit that they've developed that includes a lot of these. So our pathway is similar, but there's some slight differences in the way that we have approached it. So in our criteria, who was to be included and excluded? So protocol was appropriate for adults who have a label of penicillin allergy and are well, okay? So if someone has got, is hypotensive, is struggling to breathe, we probably don't want to be adding any complication to their medical treatment, which could potentially be an allergic reaction. So this would be generally your well adult inpatients. So anyone who's medically unstable, and it's quite a conservative criteria. So a NEWS score, for those who don't know, is an early warning score based on physiological parameters. And a score of 2 is fairly low, but something that is potentially abnormal. Pregnant, just because of course the monitoring and risks required. Uncontrolled asthma, so a peak flow less than 80% of normal or audible wheeze. Coronary artery disease, we don't really want to be putting any more stress on the system than necessary. And beta blocker are antihistamines. So the problem with the beta blocker is it can minimize your response to adrenaline and so forth. So generally, when we do all forms of allergy or drug provocation testing, we would usually suggest the removal or the cessation of beta blockers for at least 24 hours prior, just on the possibility of there being a significant allergic reaction. And the problem with antihistamines is, of course, you may minimize any reaction, and you potentially can get a kind of false negative, I suppose. So antihistamines, ideally, at least within 24 hours of the procedure, should be withheld. So this is our protocol. This is what we came up with. So first of all, we're looking for serious reactions in the top left, the type 4 reactions, the delayed hypersensitivity that I told you about. So these are a no-go, okay? And these are actually very difficult, actually, clinically to sort out sometimes, because they can be delayed, and finding the culprit medication can be difficult. But in this case, as soon as these issues are mentioned, you're not going to go anywhere near it, because you're going to commit, once you've given someone a medication that causes one of these reactions, you've kind of lost control a little bit, because that reaction will take a time to develop, but unfortunately will take a time to also go away and may need quite kind of lead to systemic symptoms. So type 4, we're not going to go down that route. And then we've got our type 1 hypersensitivity, and we're looking at our kind of high risk features. history of type 1 hypersensitivity, collapse, facial, throat swelling, breathing difficult, onset, itchy rash. Yes, look, we're not going to go there either. And then we go down symptoms typical of intolerance rather than allergy. Yes. And you don't need to then delabel. So if they've got no symptoms that's typical of allergy, such as nausea and vomiting, you can remove the allergy record. But it's important to say, just because they have intractable vomiting, let's say from penicillin, they may not be able to receive the medication, but at least you know there's no allergy there. So if you were to use other penicillin formulations, it would actually open up treatment for the patient. For those that have kind of lower risk symptoms, we move across to the orange box where we have further criteria, the time since reaction. If they had any recent reaction, hospital admission, then we wouldn't go down the challenge. So once again, we move into the middle box, the amber, where we'd go through a challenge. In terms of our challenge, we looked through a bit of a systematic review of the available data, which took in about 3,000 patients who had gone through direct penicillin challenging. And it looked actually that of all the cases, such as in the marine study, which I mentioned earlier, it happened actually at the full test dose. There didn't seem to be any utility in going for a two-step protocol. And therefore, our protocol will be a one-step protocol. The patient will be observed, or is observed for 60 minutes in total with regular observations. And of course, it's important that both the clinicians, nursing staff, and everyone know what is going on. Negative tests would be, of course, no symptoms. Itch without rash or globus sensations can sometimes be can sometimes cause but are difficult to diagnose. And that's why we'll have the utilization for this pilot. We'll be using our clinical infectious disease specialist will be supervising these. Sometimes it can be difficult to decide if what the test is, and then that will be reviewed by our group, the Penicillin Allergy delabeling group, and we will decide what's the best way to proceed. And sometimes that may relate to outpatient specialist review and going through a more traditional pathway. Of course, if there is a positive test, the patient experiences a rash, breathing difficulties, then that's a confirmed allergy, and that would be a positive test, and they'd be informed. It's really important, don't mind coming down now, that the results are documented in the medical notes. The drug chart, if it's inpatient, will be an inpatient, is updated accordingly. The ward staff are informed of this change. The patient is aware, and a standard letter, which we talked about earlier, is sent to the primary care physician who's looking after the patient, and the letter is also sent to the patient, and the letter is already also sent to ourselves. So essentially, that both the person providing long-term care to the patient, the person providing immediate care to the patient, and the patient themselves is aware of what has occurred and the changes or confirmation of their allergy status. So where are we? Well, this protocol has been approved by the Medicines Management Group at Cardiff Vale. We're starting a pilot this month in 2021 who will be utilising the infectious diseases registrar as initial point of contact to supervise the challenges. We're meeting on a regular basis to look at the results to make sure there's no safety concerns. And the aim will be therefore to incorporate, as you saw with other protocols, that it can be potentially incorporated into our local microguide and become a significant part of our antimicrobial policy. And I think the other kind of opportunities is moving on from this work is to look at ways that maybe, as is happening in Scotland, that we can look at an all Wales level that this can be developed. And I think this the other thing is the oh, sorry, I'll just get rid of that. There's also the possibility, so some places, particularly with children, have looked at the utilisation of primary care, but I think that may be some distance down the line. Incorrect penicillin allergy is a barrier to good care. It's the risk stratifications of patients is key in this. And we can see this even where there's not direct challenge performed. Skin prick testing, intradermal testing is not actually always necessary. And of course, there's a resource implication. Delabeling is successful in changing prescription. We can see that people who are delabeled will go on to receive penicillins. And delabeling does not need specialists. It just needs a sensible, clear protocol. And unlike many other medicine interventions, delabeling is actually recurrent. So once the patient is started on their penicillin, then they will be receiving that medication for the rest of their lives. So every time they're having and needing that medication, they will be able to have it. So thank you for your time. I'm sorry that was an awful whirlwind overview, I suppose, of drug allergy and penicillin delabeling. I'll now leave the floor open to yourself if you have any further questions.